What type of shock? If I have a kid, high temp, high sugar. So you're telling me all the shocks are the same?
Yeah.
They are.
Is it 104 kids though?
No, I just throwing a number out there. All right. In other words, if you run on a kid and he has a fever and an infection, the type of shock he could end up in is sepsis. All right. So basically, yesterday to today, all of our shocks are the exact same. Our treatments are the same, except our treatments are based on the kid's weight. All right. Yesterday, in a mild allergic reaction, we give Benadryl. In a kid, in a mild reaction, we'll give Benadryl. But instead of 25 to 50, we would give 1 milligram per kilogram. It would just be based on the weight. Yesterday in sepsis, we gave fluid. So what are we going to do in pediatric sepsis? Fluid. So it's all the same. It's just weight based. Okay? Now, yesterday in compensated shock, also called early reversible or localized, the pressure was above what number? 90. To be decompensated, late, generalized, or irreversible, it had to be below what number? 90. So above was compensated, below was decompensated. Because kids' blood pressure ranges the older they get, we have to use the pediatric blood pressure formula. The pediatric blood pressure formula is 70 plus 2 times their age. All right? That will equal their systolic pressure. If it is less than that, the kid is decompensated, or late, or generalized. All right? Same terminology we used yesterday. We're just, instead of doing a hard number of 90, we're basing it on the kid's age times 2 plus 70. So if I gave you this, 4-year-old male, cap refill, 3 seconds, BP, 80/40, heart rate, 118. What best describes this kid? Compensated shock, late, irreversible, or generalized?
Compensated.
Well, first of all, those 3 things mean the same thing. And a 4-year-old should have a blood pressure of at least what? 78. 2 times 4 is 78. What if they gave you this and they said, how much fluid should be given? And they go 280, 300, 320, 340 mils.
How much do they weigh?
They don't give you a weight.
16, so 20. 360?
Close. Do your math again.
40.
No. Here's how we figure this out. If they don't give you a weight, okay? This is my blood pressure formula. Here's my weight formula. Age times 2 plus 8 equals their weight in kilograms. My fluid bolus is 20 mils per kilo. Okay? So what's this kid's age? 4 times 2 plus 8 equals 16 kilos. 16 times 20 equals 320 mils, correct?
Oh, okay.
So I had to take the kid's age, plug it into my weight formula. Age times 2 plus 8 will give you their weight in kilograms. My fluid bolus is 20 mils per kilo. So 20 times 16 is 320 mils. So how much fluid should I give this kid? 320 mils. That's the max. Kids, we can give them a full 20, and here's why. Kids are borderline dehydrated before they are ever sick, injured, or in respiratory distress. If any of y'all have toddlers in here, or had toddlers at one time, I've never met a toddler that goes, hey Dad, it's 103 tomorrow, I'm going to be riding my bike a lot, I need to pre-hydrate today. Kids only drink when they're what?
Thirsty.
Thirsty. And when they're thirsty, it's already too late. So they are borderline dehydrated before anything ever happens to them. They're borderline dehydrated before they start nausea, vomiting, diarrhea. They're borderline dehydrated before they have asthma or bronchitis. And so they start out low containers so we can give them the full 20 mils per kilo. The other thing of it is their heart's relatively pure. Their vessels are relatively pure. So from a cardiovascular standpoint, they can handle additional fluid because they don't have all these years of biscuits, gravy, bacon, sausage, beer, weed, and all the other crap that you put in your bodies. So they're cardiovascularly pure and they're borderline dehydrated. So we can give them the full 20 mils per kilo. And if that doesn't work, we can repeat it one time at 10. But we're going to give them 20 initially. Anybody that's older than a neonate gets 20 mils per kilo max. In a kid, you can give them the full 20 up front because they need it. They're already dehydrated. All right? So that's how we figured out the weight. H times 2 plus 8, and then 20 mils per kilo. Same question. What best describes condition? Decompensated shock with adequate perfusion. Oh, I forgot to add this. Cap refill, 3 seconds. All right? Decompensated shock with adequate perfusion. Compensated shock with adequate perfusion. Decompensated shock with inadequate perfusion, or compensated shock with inadequate perfusion.
Last one.
So let's start at the beginning. His pressure should be a minimum of 78.
Yeah.
He's above 80, correct? So technically, by definition, he's compensated. But the cap refill is what? Delayed. It's inadequate. Here's what's happening. Remember, kids can compensate a whole lot better than adults. So compensate, and then they die without warning. They are so good at shutting blood from their extremities because they're cardiovascularly pure that they can shun all the blood away from their fingers and toes, delay that cap refill, and keep that pressure above 80. The pressure's above 80, so he's technically compensating, but he's not perfusing his extremities. He has stolen that blood from the extremities, so his perfusion throughout the body is inadequate, even though he's able to maintain his pressure at this time. If I would have made the pressure below 80, then the answer would have been what? Decompensated with
Inadequate.
What if I made cap refill 1 second?
Adequate.
Then it'd be compensated with
Adequate.
adequate. What if I did this?
What's the threshold? 2 seconds?
Less than 2.
Okay.
What if I did this? 60 over 40, heart rate 78, cap refill 1 second. Okay, let's stop and think about this. So he is decompensated because his pressure is less than 78, but he has a fast cap refill.
So it's a spinal shock.
Or
Septic.
he has something that vasodilates.
Goddamn.
So you see,
Fucking doctors, bro. All right, we'll
you're
get
going to
there.
get your license, and they're going to put this on it, and you're going to go, what the fuck's DR?
Yeah. Well, what does that mean?
Yeah, what's that mean? Hey man, what's the number to 911? There you go, Danny. So, in vasodilation or vasogenic shocks, remember the blood pressure's low, but all the blood is directly where? In the fingers and toes because of vasodilation. So, anaphylaxis, sepsis, spinal shock. So, if I was to say this kid fell off his bike, fell off a skateboard, fell off the counter, and we see low blood pressure with fast refill and it's trauma, that kid would be what? Spinal shock. If I gave him a fever, if I was to give him a fever, I would probably have to do what to the heart rate?
Speed it
Increase it, or if I was to get anaphylaxis, I'd have to increase the heart rate. But just remember, if you have a low blood pressure but fast cap refill, we haven't lost blood, it's vasodilation, which is distributive, or vasogenic shock, like what we had yesterday in the adults. Treatment for these is usually what? Fluids. Fluids and transport. All right? So, all of our shocks from yesterday apply to today, except we're going to use the blood pressure formula to determine compensated versus decompensated, and we are going to use the weight formula if they don't give it to us. Okay? I would expect that a handful of questions on the registry that make you give a drug or make you give fluids to pediatric, they will not give you the weight. All right? But that's okay. To me, this goes back, if we have the formulas on our dry erase board, that is a easy college level question to pick up. You have a 5-year-old, how much does he weigh? Well, 5 times 2 is 10 plus 8, and that kid weighs 18 kilos, yes.
You keep mentioning these college level questions. What's the difference in the test?
The what?
You keep mentioning college level questions first.
So, here is the way this works. All right? So here is the test, and the questions are rated on a freshman level, senior level, and college level question, with the average reading level on the test being 11th grade, which is why I made you do what back in October? A reading assessment. Not just Jackal. So here's a freshman level question. What color is the sky? Blue, red, yellow, or green?
Blue.
Blue. That's a freshman level question.
Damn, I have to think about that.
What color is the sky? Medium blue, royal blue, yellow, or green? It's one of the blues. So there's 2 correct answers there. College level will be what color is the sky? Medium blue, royal blue, native blue, or Indian blue? And you're like, it's fucking blue. That's a college level question. So if I relate that back to this test question, where you had to take a kid's age, figure out his weight, and then take his weight and figure out the amount of fluid, you had to work 3 parts without having any information. That's a college level question. If I would have said blood pressure 70 over 80, is he compensated or decompensated? Or 70 over 40, I mean. If I would have said blood pressure 70 over 40, is he compensated or decompensated? That's pretty cut and dry. It's either above the number or it's not. But when you start having to work it from different angles, kind of like if I said, you have a kid with stridor, respiratory distress, and barking cough. But instead of saying that, I said, you have a viral infection with a low-grade fever that worsens at night. Is it laryngeotracheal bronchitis? Is it parainfluenza B, hemainfluenza B, or epiglottitis? It's croup, but the viral name of croup is, so you see how I gave you a very subtle sign and symptom of croup, and I made you work backward through signs and symptoms to come up with a viral name. That would be a college level question. Another example would be, you have a patient on the ground unresponsive. Should you A, open the airway, B, check for a gag, C, check for a pulse, or D, consider C-spine?
Check for a pulse. Everyone. Pulse. He doesn't have a pulse.
C-spine.
CPR.
It's C-spine, then pulse, and next one.
You're going to do all of them, right? But which one would you do first? C-spine. Because C-spine dictates, C-spine does not mean C-colon backward. C-spine means, do I do a jaw thrust to open the airway, or do I do a head tilt chin lift? He's on the ground unresponsive. I don't know how he got there. I'm going to jaw thrust, open the airway. Is he breathing or not? No breathing, check the pulse. I'm going to do all those, but I have to consider C-spine before I go moving them, and C-spine dictates how open the airway. So that would be a college level question. Because every one of those answers is something that you can reasonably do.
They put that on the driver's test that they just took, and they took it off because so many guys argued against it. It was that exact same question.
That's awesome.
Yes, the medical question on
Because you got to be a paramedic.
It's like I'm a driver. I'm not getting off the engine.
Yeah, but what if you're, what is it? Paramedic A, driver, whatever.
Yeah, rescue driver.
So are those scored differently on the test?
So here's the way it works. And yes, they are. But they won't tell you exactly how. So many beverages and 20 plus years later of knowing the people up there. And basically, here's what happens. Let's say that I have to get to 70% here. All right? To pass whatever subscale, cardiac, whatever. So let's say I ask you a freshman level question, you get it right. I ask you a senior level question, you get it right. I ask you a college level question, you get it wrong. I ask you a senior level question, you get it right. A college level question right, college wrong, senior right, college wrong, senior right. I am now at 70%. You would be cut off if you perform this way throughout the entire test at 80 questions. And you passed it. All right? Because it's not so much did you get the college level questions right, you got all of the easy stuff. And that's why I'm saying that easy stuff is the key to passing the test. That meat and potatoes. That college level question, when I start throwing these formulas, that's just gravy on top of that meat. Because you have to get all the easy stuff right. You got to get the cut and dry stuff right. If you can't get the cut and dry stuff correct, you have no chance of passing that test. And here's what's going to happen. So let's say that this guy gets cut off at, say, 80 to 84 questions, and he passes. So your buddy goes in, and he does this. Freshman level wrong, freshman level right. Freshman wrong, freshman wrong, freshman right, senior wrong, freshman right, senior wrong, freshman right, senior wrong. He's going to get cut off at 80s, and he's going to have failed everything. He couldn't even get enough freshman level questions right to increase to a college level question. He's going to get cut off in the 80s, and his results are going to say below passing. That test knows in the first 10 to 20 questions whether you're going to pass it or not. Because stop and think about it. If I ask you 10 questions and you got all the senior and freshman level questions right, you're going to be proficient. If you can't even get what color is the sky, red, yellow, blue, or green, if you can't pick blue, you're probably not going to pass. So if you get cut off at 80-ish, you kicked its butt or it kicked yours. There is no in between. Now, a lot of students will go 90 to 100 questions.
Theoretical.
And then you get the students that go to 150. So to go to 150, here's what happens. They basically go right, wrong, wrong, right, 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 wrong, wrong, right, wrong, right, right, wrong, wrong, right, wrong. They can never quite get to the cut score, but they never get so far below they're mathematically eliminated. This person's probably going to go to 140, 150. They're probably going to see this on their results. Let's just say that I got airway breathing, cardiology, OBPD, medical, and operations. All right? This is the results you get when you log in. And they've actually combined, I think, cardiac and medical, but it gives you an idea. If you miss that subscale by more than 3 questions, it says below passing. If you got it within 3 questions, it's going to say near passing. And if you passed, you passed. So it may say this: passed, below passing, near passing, below passing, passed. Here's what happens on the next go round. Below passing, near passing, passed, near passing, below passing. And then I get a phone call, dude, this is kicking my butt. And I'm like, okay, so let me guess. Everything you passed the first time around, you failed the second time. How'd you know? Because that's what happens. So guess what's going to happen on the third time? Near passing, pass, below passing, pass, near passing. That's exactly what's happening. You were like, dude, I got airway. I'm not even going to study it. Reality is, if we come back to this kid, if this was airway, how many questions did this kid pass airway by? Right on the mark, which could have been a lucky guess. So if he chooses not to study like he failed airway, he misses 1 or 2 questions on that retest in airway, he's gone from passing to bombing it. And he was like, oh, I'm good in airway, I don't need to worry about it, man. I got a lot of work to do in cardiology. I'm close to OBPD. I'll spend a little bit of time in it. Man, I got to work real hard in medical. I'm a fireman. I got ops. And so they blow off studying. Heaven forbid you have to retake this test, but you need to focus like you bombed every one of those sub-skills. If not, it's going to become a mental game, and your results are going to constantly flip-flop. This right here passed the test by 1 or 2 questions. This failed that one by more than 3. This was within 3 of passing, below more than 3 from passing, and that was right on the money or 1 or 2 questions. So that one question you passed by might have been a lucky guess. You still passed. But in your mind, you're like, I got this. And you don't remember back to when you bombed it. So if we look at this, 3, 5, 8, this person probably missed this test by 8 to 10 questions. Which is why the dry erase board becomes so important, because we can pick up some of the numerical stuff and some of the formula stuff by having it in front of us. And if we can pick up an extra 5, 10, 11 questions off our dry erase board, that puts us so much closer to success. That's where that comes in. That's why it's important to have a dry erase board and fill it out when you go in there. Because, not to be rude, but if I was to sit there and say, you have a 5-year-old male, how much fluid should you give? If you don't have that formula down, you're probably, if you've been in there an hour, you see that, you're like, you got to give me a weight. No, they don't. You do not have to have a weight to figure out a pediatric, but you better know the formula. And that's why those formulas come back and help us out so much. Drug counts. Missing a drug count question is not going to make you bomb the test. Missing a GCS is not going to make you bomb a test. But here's what's going to happen. You get a GCS question, whether it's an adult or a pediatric, you get a GCS question. Clean this up. And the answers are 5, 6, 8, and 9. That's the answer for the GCS. And you did it in your head, and you get 7. So do you pick 6 or do you pick 8?
I probably forgot one.
So you got a 7, and you get a 6, and you get an 8. So you click 6. The next question, you're like, man, should I pick 8? So the next 2 or 3 questions, are you even fully reading them and getting that 7 out of your head? Or are you sitting there going, God, I picked 6. What if I should have picked 8? What if that makes me fail the test? Versus you have your GCS on your dry erase board already. Oops. Which is 4, 5, and 6. This is the way I remember it. All right? It's 4, 5, and 6. 1 is always none. All right? 1 is always none. This is actually AVPU. Alert, verbal, unresponsive. So, if they're talking to you, they get a 4. If you have to yell at them, they get a 3 for verbal. If you have to do painful response, they get a 2. That's my AVPU. That's my IOB. You're not typically going to see a test question that says, you walk in, 27-year-old male spontaneously blinks. They're either awake, respond to voice, respond to pain, or they're unresponsive. Number 5 is speech. It's either perfect, confused, inappropriate, where they make a noise. Moaning and groaning is a noise. Fair enough? 6 is perfect. 5 localized. 4 withdrawal. 3 decortic. 2 disseverate. So now we have this on front of us, and we read the test question, and it says 27-year-old male responds to pain, moans, and withdraws. So I got a 2, a 2, and a 4. Move on.
I guess you missed that one.
Huh?
I guess you missed that one.
But you see how stress-free it is now. Because the 2 to 3 minutes I spent before I ever logged into that test, or before I cloud my mind with an hour worth of stress, I dumped all that stuff on the dry erase board to where now 45 minutes, the GCS pops up. I'm not trying to write it from memory after being in there an hour. They asked me a pediatric fluid bolus. I'm not trying to write it from memory. I look in front of me and it's right there. I'm not trying to remember what a 7-year-old's blood pressure should be. It's right there. I'm not trying to remember how to do a drug calc. It's on the top of my dry erase board with that 3 zeros divided by the back. I'm not trying to remember all that stuff after I've already been in there now. I'm trying to remember it from the truck, hand the lady the license, set down, and purge.
So if you do miss that one, you're gonna get another one of those questions, correct?
More than likely.
Yeah, man, keep doing it.
Yeah.
They did that with me on like anaphylactic shock.
Yeah.
I had like 8 in a row.
Yeah.
And I was reading up on it before I went in to take the test. I was like, I don't need to know that. They literally went in there and they like.
When they find that weakness, they're gonna start kicking it.
Yeah, I passed.
So you're saying that
You probably went to 120.
I did go to 120.
you're saying if we get to question 1 and it feels like a college question, we're fucked?
No. No. If question 1 is a college question, you get it right, the test is going to be, all right, well, we started him off hard. Here's some easy ones. You get those. He's proficient. Let's get the data we need out of him.
Oh, okay.
Yeah, just because you start with the college question doesn't mean you're fine.
I was about to say, like, they're supposed to get harder, and that one was like, oh, shit.
Yeah.
Oh, yeah. You got Montana.
What's going to happen is it's going to go, machete. That's what's going to happen. As soon as that camera sees you pop up, you failed. No. But, and that's why it's important, to me, that's why we got to get the meat and the potato stuff first. And then we can pick up those college level questions where they gave us the age, and we had to get the age, create a weight, times 20 to get the fluid bolus. To me, that's an easy college pickup question because we got the formulas. If we don't have the formulas, it's going to be hard to get it. Yes, sir.
I was just asking, like, how big, like, how much shit can you put on?
Okay, so it's about 11 by 13. You should have had it when you went to EMT school. Did you even look at it? Did they give you scratch paper?
Yeah, they did.
Yeah, they do.
Did you use it?
No.
So, like, for equations and shit.
Okay? So, depending on what Pearson testing center you go to, they're either going to give you a dry erase board or paper. Here's the rules. You can't erase anything, and if you fill it up, they're going to take it and give you a new one. Because they assume if it's completely full, you need more space. You also have to understand that a lot of times, now if y'all go in there together, it's different, but a lot of times he could be taking a real estate test, he's taking an accountant test, he's taking irrigation, he's taking plumbing, he's taking law, she's taking a nursing exam, and you're taking an EMT exam. So the workers don't necessarily know which exam you're taking. What they tell them is when you're watching the students on camera, if they erase anything, we are going to go pick up their dry erase board because we want to see everything they write to cut down on cheating. So if you're racing something, they feel like you're hiding something. It's just the rules. And if you fill it up, they're going to assume you need more space. So you're going to be like, oh, you filled it up? Here's a new one. You're like, whoa, but I'm not done. So here's the kicker. What I will typically do is on the right corner of the board, I will draw a line like that, a little box. If they say, hey, it's full, no, I still got my blank area, see? Just game of the system. All right? And if you have to do anaphylaxis, or not anaphylaxis, but GCS or something, just put a line under it when you're counting. You may not even have to. You just be able to go, okay, pain, moans, withdrawals, okay, there's an A. If you got to do a drug calc, I always put my drug calcs on the top left. That way I got this area up here to work. And then I'll go my pediatric formulas, and then I'll go my GCS and APGAR, and then my rule of nines. All right, in your rule of nines, you should have 3 sets of rule of nines. You should have your adult, or pediatric, and then your fathead 5,000 baby. And I draw them like that on purpose. That way I know my adult is 9, pediatric is 12, infant is 18. Okay? Now, on all of these, arms and trunk are the exact same. The only thing that changes is what? Legs and the head. So 16 and a half, 16 and a half. This one is 13 and a half, 13 and a half, because that's my infant. Kid, adult. So if it says you have a 2-year-old, left arm is burnt and left leg is burnt, well, I come over here, a kid is 1 to 12. So I look at it and I go, okay, left arm is 9, left leg is 16 and a half, so that kid is 25.5% burn. Move on. You have a 6-month-old circumferentially burned to the right leg and to the trunk. Circumferentially means all the way what? So his entire trunk is 18 front, 18 back,
36.
and then 13 and a half for the right leg. So he's 49.5%. It's all about using the tools they give you for your tactical advantage. Creating a tactical advantage is the goal of that dry race board.
So other than that, what else do you have on there? You said. Yeah.
So I do drug calcs. All right. So here, and then we'll finish up with pediatric. Do you have a question?
Yeah.
Okay. So normally, and this is just me, and what you're going to find is your dry race board is going to change between now and you take the test. Because you need to spend anywhere from 5 to 15 minutes a day doing your dry race board. And just randomly take out a sheet of paper and practice it to where you get it down to where you can do 2 or 3 minutes. Don't spend an hour doing your dry race board. You will run out of time taking the test. Spend 2-3 minutes. All right? So I will normally do this. 1 equals 1,000. 1 gram equals 1,000 milligrams. 1 milligram equals 1,000 micrograms. Drug, add 3 zeros, divide by IV bag, equals question mark over 60. That's a little hard to write with right there, but that's all right. And then I'll do drug X colon 1 equals X on top of the clock. So there's the drug formulas that I will need. The fluid formula yesterday was fluid times drop set divided by time equals drops per minute. I guess I should write bigger, but I don't want to run out of room.
Yeah. I can't see it, but
I know. All right, drug add 3 zeros, divide by the IV bag equals question mark on top of the 60-second clock. Drug X colon 1, X goes on top of the clock. Remember, that's like saying you have a drug supplied 16 to 1, 8 to 1. 1600 to 1 like dopamine. That goes on. So if I said drug X is 1600 to 1, that means you have 1600 for every 1 mil of fluid. That 16 would go on top of the clock. All right? That's what that drug X : 1 means. All right? Let me draw the fluid formula. So fluid times drop set divided by time equals drops per minute. I also do this. IVIO equals 10. PDIV equals 60.
That's less than 12, right?
Yes. And now basically what we're looking at is our PD formulas, which is age times 2 plus 70 equals BP. Age times 2 plus 8 equals weight in kilograms. Age plus 16 divided by 4 equals ET tube. ET tube size times 3 equals centimeters at the teeth. We got our rule of nines, we got our GCS, do our APGAR, appearance, pulse, grimace, activity, respirations. The difference between APGAR and GCS, GCS 1 is none, in APGAR 0 is none. So if I said you have a kid that's limp with no pulse, no response, they're cyanotic and they have no respirations, they get a 0 across the board. If everything is perfect, he gets a 2 in each category. If he's barely breathing, has a low heart rate, he's not crying, coughing, or sneezing, and he has a blue extremities but pink body, he's going to get the 1s. So let's say he's actively crying, but his heart rate's below 100. So actively crying, a 2, pulse below 100 would get you a 1. And we're just going to go through and add the numbers. Put it in your own words. I wrote the GCS in my own words. Write your APGAR in your own words. Maybe instead of activity, you want to go, how's he moving? Maybe instead of pulse, you want to go heart rate. I don't care, but you need to get it to where it's in your own words, to where whenever they tell you on the test, you know what it means. And it's up to you. I suggest drawing your rule of nines, but it's up to you. Maybe you want to write them out. Maybe you want to write, adult head 9, kid head 12. Infant, head 18. Maybe you want to write like that. I don't know. You know yourself better than I do. Your dry erase board is yours. If you are worried to death about the dose of amiodarone, put it on your dry erase board. If you are scared to death of what do you cardiovert a kid at, put it on your dry erase board. If you are scared to death that they're going to ask you semi-trucks, which they are, draw them. The first roughly 11, 12 pages out of this thing, this is why this has an 11-page document under your study guides on eCampus. Because see these pictures right here of the semis? They're going to show you the back and side view of this one right here. It's at 406, which carries what?
Fuel.
Gasoline. These pictures right here are game on the registry. and they will show you this back view and the side view. That carries gas. Oh, that one right there, gasoline. If you go to eCampus under study guides, guess what's on there? A hazmat with just the placards and the pictures of the trucks. You know why? Because that's on the registry. You know why it's on the registry? Because you were supposed to be trained to the hazmat awareness level and know how to use this book as an EMT, paramedic, and firefighter in the United States.
I was trained out here.
Doesn't matter. The study guide is on there, and really all you got to do is look at the truck that carries acid, a 412, with the stiffener rings like a cigar, the 406 and 407 because they carry gasoline. And then they're probably going to show you a flammable liquid placard. Every once in a while, they'll show you an NFPA 704 fixed facility placard, and they will show you blue number 3, and they'll ask you what it is.
Water reactor? No.
Health. Hazardous to health. Something like that. They ask you, they show you the side and rear view of a semi that carries gas, and you get it right, probably won't see any more hazmat questions. If you can't recognize a gasoline truck as a fireman, they're going to start picking that scab and kicking you. Usually my firemen don't have a whole lot of hazmat questions or incident command questions on there because you're supposed to be proficient in it. My nurses, on the other hand, they have almost no airway and cardiology, and they get to hazmat and they're like, oh my gosh, there has to be 20 mass casualty questions. That's because you suck at it and we're getting them wrong. So yes, it finds your weaknesses and then it sees how you do. We have to be halfway decent at everything as a paramedic. You can't just go, well, I only want to run cardiac calls and I suck at everything else. Well, I only want to run pediatric calls and I suck at everything else. You have to be proficient at the bare minimum in everything related to that. There are rescue questions on that test. What's the strongest knot used in rescue? Figure 8. You will have some questions like that on the registry. Extrication, hazmat awareness, swift water, confined space, mass casualty, incident command. Those are all things that you were supposed to, as a firefighter and a paramedic, have a general knowledge of, not an expertise. If there is a hole in the ground that is greater than 6 feet, you do not go in because of collapse, and it could be oxygen deficient, correct? That's all it's asking you. It's not asking you to know raker shoring and everything else. It's saying you got a hole in the ground with a bunch of dead people, don't go in.
They're all like that.
I mean,
You have a swift water. You should not get within how many feet of the shore without a PFD on?
10.
yeah, that's kind of stuff to ask, and it's easy. But on these practice tests I'm taking for ops, and we like, EOC administrators are comprised of what staff? And it's like, I don't fucking know. Exactly. I'm never gonna know that because I'm never gonna like.
Then you're never going to promote.
Yeah, but I'm not promoting right now. I'm trying to be a paramedic right now.
But you have to know that. And here's why. All right? You respond to a mass casualty incident. You are first on scene. What do you take?
Incident command.
And what's your partner become?
Triage.
Triage to determine how many additional resources we need based on patients. If you were assigned to transportation, who does transportation report to?
Logistics.
Nope.
That's worse.
All the work gets done in operations. So, and that's why they want you to know that. In operations, depending on the size of the mass casualty or the event, in the operations, there may be a fire side that gets broken into rescue, suppression, hazmat, and then there may be an EMS side that gets broken into triage, treatment, transportation, and rehab, because you got to rehab your other workers. And that's why they want you to know that as to who you go to. Who's ultimately in charge of a mass casualty? Incident commander. Who are the 3 people that are his staff to help him get stuff done? Nope. CFLOP are the parts of command. You have command and you have finance, logistics, operations, and planning. The command staff is the liaison officer, the safety officer, and then you got to have someone dealing with the press. That's command staff. CFLOP are the divisions of incident command. If you were to report from here to Florida to assist with the hurricane, when you get there, who do you report to?
Finance.
Why finance?
So you get paid.
To where City of Dallas can officially check in and get your city reimbursed for all the man hours, fuel, and equipment. If you don't check in with finance, there's no official record of you reporting. Now, if you were to run a fire in Irving or Duncanville or Garland or Mesquite, somewhere that you border with, and you go help them with something, who do you check into?
Incident command.
Incident command, because we've already prearranged through Dallas County Mutual Aid how we're going to handle payment and all that stuff. But if you're going hours away and it's a declaration emergency, you have to check in with finance. Because I'll tell you right now, the federal government, they like to spend money, but they don't like to give you money. So the only way your city's going to get reimbursed in those mass casualties and those things that go a long ways away, you're going to have proof you checked in. You're going to have proof you were actually there. You're going to have to prove that that ambulance that you and your partner drove to Florida, that the city actually owned it and they actually had insurance on it.
Mm.
That's the way it works. Huh? Yeah. But I mean, that's because they're going, hey, thanks for coming and helping. We appreciate it. Oh, wait. You sure you actually owned Boca here? Was it actually compliant? Did you really own that ambulance? And they're looking at ways not to turn around and reimburse. And I know that sounds crazy, but that's why that finance piece is in there. All right, and we'll talk about that more in a minute. We kind of got off track, but that's why those things are on the registry. All right? You don't got to like it. You just got to pass it. I can lead you to water. I can't make you drink, but I can hold your head underwater and drown your ass. And it's up to you whether you try and learn or not. You got all the information. All right? Rule of nines. Parkland burn formula is another one to put up top. 4 mils per kilo times the body surface area equals total fluid in 24 hours. We give half in 8 hours, and then we give a second half in 16 hours. Have you guys ever actually done a Parkland burn formula? Like to figure out the actual math? So let's look at this. 4 mils per kilogram times the body surface area burned. So let's say that I have a 100 kilogram patient burn 20%. That is 8,000 milliliters of fluid, or 8 liters. 400 times 20. All right, am I right? 8,000? That's 8,000 milliliters of fluid, or 8 liters. Let's tap the brakes. In 8 hours, they only receive 4 liters. So they're really only receiving about 500 mils of fluid an hour. How long are we with them?
10 minutes.
So they only need about 100 cc's from us. At first glance, you're like, oh my God, they need 8 liters of fluid. That's in a total 24-hour period. You're only with them 10 minutes of that. So really, from us, they only need maybe 50 to 100 cc's of fluid, maybe a couple hundred. But they're going to ask you how much total fluid does a patient need versus how much fluid should they receive in the first 8 hours versus how much should you give them in your presence. Well, if they want to know the total amount, it's 8 liters. If they want to know how much in the first 8 hours, it's 4 liters. If they want to know how much you're supposed to give in the 20 minutes you're with them, well, if they're getting 500 an hour and I'm with them a third of that, they're roughly going to get about 150 cc's. That's it. It's not a ton of fluid. But if you don't have this up here, and they say how much fluid should you give a burn patient, blah, 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 in an hour, you're going to be like,
You don't need the weight.
huh?
But you don't need the weight.
You have to have the weight. They'll give you the weight. It's 4 times their weight times the amount they're burned.
So what the college
Because unless
level
they're
be for
pediatric
how much
patients,
you
they
need
might not
on
get
scene?
it, right?
Do what?
So the college level would be how much you need to give them on scene.
Or it would just be, can you take a question, put it back, plug it into a formula, and then turn around and select the best answer? You have 3 moving parts to that question. Once again, that's not a dry erase board. Dry erase board. Those are some of the minimums you should put. Whatever scares the crap out of you, start doing it between now and then. I will give you paper when you go to take both finals. That way, before you start your final, you can write any of that stuff down you want. But it's got to be from memory. I'm not letting you walk in with a dry erase board filled out because they're not in it. All right? Use it to your advantage. I am telling you that I will allow you a cheat sheet on your final. But it's got to come from here to the paper when you walk in the room. Why not take advantage of that? Because all that's stopping you from doing it between now and then is putting in the work. 15, 20, 30 minutes a day. What you're going to find is the more times you write it, the less stuff you end up putting on that dry erase board. Because remember, you remember about 90% of what you write and say. You only remember about 5% of what you read. So the more times you write this dry erase board, the more it's going to become automatic to you. And you may start out with, man, you have everything. And then by the time you get to May 5th, you're like, oh, yeah, I'll put this stuff down. And then you're taking the test and you find yourself not even having to really use it because you've spent so much time putting it in your memory. But if you vapor lock, it's a safety net. All right? Does that kind of make sense? That help clarify some of the things on the dry erase board. Anything else you suck at? You ain't got enough room for you, Montez. All right, so let's keep going with page 8. All right, keep going with page 8. What is the difference between pediatric asthma, pediatric bronchitis, and bronchiolitis? First of all, they all have wheezing. They all have coughing or grunting. They all get albuterol. The second and third, they get albuterol plus Atrovent. Where did we hear that? This morning in adults. And then they also get steroids and fluids, just like an adult. If kids are borderline dehydrated and they go into respiratory distress and they're doubling the amount of times they exhale, what's that going to do to the secretions? Because every time you exhale water vapor. It's going to dry them up, and it's going to make that secretion for the asthma, bronchitis, and bronchiolitis that much thicker and harder for them to clear it and breathe, so they need fluids as well as the albuterol. One of the best things you can do for pediatric bronchitis and asthma besides albuterol, give them fluids to help them that secretions. Now, I'm not telling you to stick that kid 20 times. I'm telling you to try one. The more times you try to start a pediatric IV, the better your confidence is going to get to where the day when they truly need one, it's not the first one you've ever done. Practice. As y'all know, I run the Children's Flight Nursing Program. So we get nurses from Children's Transport Team and we make them paramedics in 12 Thursdays.
Say what?
Yeah. We take their nurses from the ER that want to fly, and the nurses on their transport team, and they start, and in 12 Thursdays, we make them paramedics. So they go around the Metroplex picking up sick kids, and they all say the same thing. Their biggest pet peeve is they go rolling up to an ER with the kid in respiratory distress with asthma or bronchitis, and the kid is dry as a bone to the point that they can't even get that mucus to move. And the ER and the medics were afraid to try and start an IV on them. And they're like, that's the first thing we do is freaking start an IV and start dumping fluids in them to thin those secretions to where the medication works better. We get afraid of doing it because you haven't done a whole lot. Practice. Don't stick that kid 10 times, but try 1 or 2. Usually right here, there's a secret squirrel vein right there on top of the wrist on the side, right through there. Sometimes you can double tourniquet, get it to pop up. Sometimes you can get a little 24 over there by the pinky. Use 2 tourniquets, but practice. Try it once or twice, all right? Get your confidence up. Now, how do I tell the difference between asthma, bronchitis, and bronchiolitis? Asthma is over the age of 2 and will not be associated with fever or congestion. Bronchitis can occur in any age. It's bacterial, and it's typically associated with fever, cough, and congestion. Bronchiolitis can occur in any age. It's viral, and it's usually associated with fever, cough, and congestion. So you need to write bronchiolitis out there besides bronchitis. On page 8. They're the same thing, except one is viral, one is bacterial. So here's what the registry is going to say. You have a 6-month-old wheezing, grunting, congestion, and low-grade fever. You suspect what bacterial infection? Bronchitis. You have a 6-month-old fever, wheezing, congestion. You suspect what viral infection?
Bronchiolitis.
Bronchiolitis. You know how the pediatrician tells the difference between bronchitis and bronchiolitis? They don't. You take your 6-month-old in, they got a cough, they got some wheezing, some congestion. They go, your kid has bronchiolitis. Here's some albuterol syrup, because we can't get a 6-month-old to use an inhaler. Here's some prednisone or Decadron steroids. If they're not better in a week, call me back. Your kid has bronchiolitis. It's viral. Everything's viral. A week goes by, your kid's not any better. You go back to the pediatrician and they're like, must be bronchitis. Here's some augmentin antibiotic. That's what the pediatricians do. We're not going to treat asthma, bronchitis, or bronchiolitis any different in the field than albuterol, butyryl atropine, look at fluids and steroids. They just want to know if you know the difference between asthma, a chronic condition, and an infection in a young kid. That's it.
So before 2 years old, we had a call like this not too long ago. It was a chronic breathing difficulty. This little girl, she was just under 2 years old. Mom said that the doctor wouldn't diagnose her because she wasn't 2 yet.
Correct.
But she still had constant breathing problems.
Correct.
So what do you, like, as a parent, what would you do for that?
You know why the doctor doesn't want to diagnose them with that? Because their lungs aren't fully developed, and you don't want to stereotype that kid with asthma and affect its ability to get insurance as it gets older, and it still may not have asthma. So they typically will wait till they've grown enough and their lungs have developed and they're over the age of 2. It's not as big a deal now, but when I was a kid, if you were diagnosed with asthma, your parents' insurance wouldn't cover you anymore. So that kid would no longer have insurance, and that's why they've typically waited. Plus, they want to make sure the lungs mature and they truly have asthma, and it's not just any inflammation or allergen gets in there and causes it to react. And so they're going to wait till the kid's matured enough to see if it's truly asthma or if it's an allergen. Asthma can be triggered by allergens. The other name for asthma is reactive airway disease. You get dust, mold, pollen, pet, dander in there, and all of a sudden it causes the bronchioles to spasm and react, and that's what they're trying to make sure. It's actually a disease versus an allergen that's causing it. And
Yeah,
that's
we gave her
another reason why
breathing
they're waiting.
treatment. And she,
Yeah, you're going to treat it the same. We hear wheezing, we're treating it the same. We really don't care what it came from. We're going to treat it the same.
You said they're both viral?
Bronchitis is bacterial. Bronchiolitis is viral. We're going to skip croup. Meningitis. There's viral and bacterial. Viral is no big deal. Bacterial can kill you. Viral makes you pretty sick, but it's not typically going to kill you. Regardless of age, fever, headache, stiff neck, also called nuchal rigidity, light sensitivity, those are all signs of meningitis, regardless of the patient's age. Doesn't matter if they're 2 months old or 50 years old. Headache, fever, stiff neck, light sensitivity, we're going to assume it's meningitis till proven otherwise. Protect yourself with mask and eye protection. If the fontanelles are sunken in a baby, that's a sign of what?
Dehydration.
Dehydration. If the fontanelles are bulging, there are a couple things it could be. Now let's talk about the fontanelles. The fontanelles, you have front and back fontanelles, anterior and posterior. The posterior fontanelles close at 12 to 15 months. The anterior close at 15 to 18 months. They are where the brain is, not the brain, but the skull is not fully fused together. It allows a couple of things. During delivery, it allows for compression as they move through the birth canal. And then for the first year, it allows for the brain to develop and grow before it basically encapsulates it. That's the soft spot on the kid's head. So that's what it's there for. If it's sunken in, they're dehydrated. If they're bulging, it could be fever, an infection like meningitis. It could be a head injury and intracranial pressure, or it could just be the kid is really pissed off. Will you crack that door? So, if I was to say you have a 1-year-old who mom reports is lethargic, high-grade fever, appears rigid, and you have bulging fontanelles. Stiff, fever, bulging fontanelles is what?
Meningitis.
Meningitis. You respond on a 1-year-old. Mother states baby would not stop crying, and now he's unresponsive, bulging fontanelles. You suspect what?
No.
Wouldn't stop crying,
You
bulging fontanelles.
was just pissed off.
Wouldn't stop crying, now it's lethargic, bulging fontanelles. Shaken baby syndrome, which is a what? Head injury, intracranial pressure. Sunken is dehydration. Bulging is head injury, infection of the kid's bed. So if mom states he wouldn't stop crying, now he's lethargic, won't wake up, and the fontanelles are bulging, that's intracranial pressure. That's usually an abuse situation. If you respond on a kid who's having congestion and wheezing, and you go to start an IV and he starts screaming, and you notice his fontanelles are bulging, he's actively screaming, pulling away from your IV, that kid's just what? Just pissed. If they're lethargic and bulging fontanelles, it's either a head injury or infection. Most 1-year-olds do not get a head injury unless they're what? Abused. Now, that's not to say it can't happen. Let's say that she had a 14-month-old. You get there, the 14-month-old is unresponsive, bulging fontanelles, unequal pupils. You ask her what happened, and she said, I was setting the kid on the counter, trying to bake, and I had it up on the counter with me, holding on to it, trying to bake, and it fell off. And you go in the kitchen, and there's stuff everywhere, cooking. That's probably what happened. I know I used to put my kids on the counter all the time before their mom would come home, and I was in there trying to cook, and that happens. That's an accident. What happened to your kid? I don't know. What do you mean you don't know? Well, it wouldn't stop crying, and my boyfriend was pissed, and, I ran to the store, and I came back, and my boyfriend's gone, and the kid's on the ground unresponsive. Is your boyfriend the baby's daddy? No? Okay, so stop and think about that. Wouldn't stop crying, pissed off, don't know what happened, and now the kid's lethargic, and the person that was watching them's gone. Probably an abuse situation. Right? So those are just some of the things that make up on the test, is they're going to every once in a while ask you about child abuse. on the test. Child abuse and elderly abuse is mandatory reported. Or they may say, you have a 2-year-old, which of the following be indicative of child abuse? Choking on a marble, a burn scalding to the buttocks, burn to the left foot, or bruising on the buttocks.
Burns
Burns on the butt. Here's why. Burn on a foot, and stop and think about this. It's a 2-year-old. 2-year-olds can move around pretty decent, especially if you turn your back. If a 2-year-old goes to get in water and it's too hot, they're going to immediately pull that foot out, which would mean like a foot burn. You know, mom goes to put the kid in the hot water, it's hot, burns their feet. If the water's scalding hot and the kid knows it, natural reaction is going to pull its legs up, so the only part that's going to get burned on that kid is what? And that's a dunking injury versus you put your foot in, oh, it's hot, and pull out. What do 2-year-olds do with their mouth? They put everything in their mouth. That's how they figure out. It tastes bad, spit it out. So a marble in a 2-year-old's mouth would sound good. 2-year-old bruising on the buttocks, okay.
Yeah.
They fall a lot, and if you discipline them, not over-discipline, but usually they're going to have on the buttocks from falling, etc. That's not usually abuse, but dunking injuries will cause round buttock burns and nothing else. How else do you burn your bottom without burning your legs? That's child abuse. And so every once in a while they'll ask you a couple of questions like that. All right? How do we treat meningitis? We're going to do fluids. If we carry Tylenol or ibuprofen, we'll give it to them for fever control. How they test for meningitis is a lumbar puncture. If they do a lumbar puncture in a male patient, because of the cerebral spinal fluid, it can give them temporary spinal inflammation, and they can have a temporary priapism or some numbness and tingling. The last uncuffed tube is a 5.5. Any kid over the age of 8 gets a cuffed tube. If we go back here to our formula, and they say you have a 4-year-old, what size of tube should you give? Or here's one. Let's do this. You are transporting a 4-year-old with ET tube at 24 centimeters. What do you suspect? So here would be a college level question. You have a 4-year-old who's tubed at 24 centimeters. Is that right mainstem, left mainstem, esophagus, or trachea where it's supposed to be?
It's too deep.
Well, let's stop and do the formula. A 4-year-old, 4 plus 16 is 20, divided by 4 would be a 5.0. How deep is an ET tube supposed to be in adults and kids? 3. So times 3, it should have been 15 centimeters. It's at what?
24.
That is way too deep. Yeah, that's more likely. Let's make it this. There. How about we make it 19? There. I feel a little better. It's too deep. It's probably the right mainstem. If it would have been like 10, it's probably a what? Esophagus, just like what we talked about yesterday. So you see how I gave you an age. You had to figure out the ET tube size to turn around and figure out the depth, because they didn't give you the ET tube size at all. So we had to use our formula. Age plus 16 divided by 4. All right? Age plus 16 divided by 4. We use internal diameter. Don't worry about the age plus 2 times 8 that you're going to see on another page. Don't worry about that. Infants are nose breathers and have big floppy tongues. Why are infants nose breathers?
Because they have a bigger tongue,
So they can suckle.
Yeah.
That's how they get all the food. They nurse. An infant's respiratory rate is 40 to 60 breaths a minute, which means they're taking a breath every second. If they were to try and nurse and breathe through their mouth, they would never get any food, because they'd be like, they can't do both. So by having a big floppy tongue, it creates suckling, and they can create suction and breastfeed or nurse on the bottle. So our airway management in infants needs to also include the nasopharynx. Most infants and toddlers cannot breathe through their nose and blow it and pick it. So the only way to get their nose clear is what?
Suction.
You do it. You suction it. So if you got a newborn in respiratory distress or an infant, you need to also suction the nose, which is why we carry a bulb syringe in what kit? OB kit. Don't forget, any pediatric or infant seizure or altered, check a D-stick. How do I check a D-stick in an infant?
Heel.
Through the heel. What's another name for D-stick?
Blood glucose level.
Blood glucose level, BGL. Finger stick blood sugar, FSBS.
The sugars.
All right, all kinds of different words for it we talked about yesterday. There's our hypotensive. It works up till about age 10 or 12. All medications are weight-based, not to exceed the adult dose. All right, all medications are weight-based, not to exceed the adult dose. Let's get through page 9 real quick, and we'll take a good break. Early labor, she's having contractions. We don't check for cervix dilation. We're just going to go with if she's crowning. If she starts to crown, starts to bulge, that's late. We'll also break that down into stage 1, 2, and 3 when we move to the PD packet here in a minute. If it ain't the head sticking out, put her doggy style and drive fast. Trendelin dog, elevated buttocks, knee chest position. If you have a prolapse cord hanging out, we're going to get her elevated or on her side to get that kid's head off the umbilical cord, because if the head's pinched in the umbilical cord, it's going to cut off blood flow to the baby, and now the baby's going to become hypoxic and possibly get a brain injury from lack of oxygen. A brain injury where they don't get any oxygen because they've been suffocated is called anoxia. Oxia meaning oxygen, anoxia means without oxygen. That's an anoxic head injury. So that kid, if it cuts off its blood supply by pinching the umbilical cord up against the pelvic girdle, it can lead to brain death in the kid. So how do we do it? Elevated buttocks, knee chest position, trying to get that kid to slide off that umbilical cord and pelvic girdle. If there's no pulse in the umbilical cord, you're going to take your hand and gently push the kid's head back in a little bit to get it off that umbilical cord. All right? That is one time you can put your hands inside a female on duty and not get fired. We don't check for cervix dilation, but we can use our hand to get that kid's head off the pelvic girdle. That's called a prolapse cord. If it starts to deliver and the prolapse cord is wrapped around the neck, what do we try first to get rid of it? Slip it off, take your 2 fingers, slip the cord off. If that doesn't work, clamp and cut. Make sure that we don't have a pulse between our clamps though. Breech. If it ain't the head, put her doggy style, drive fast. There are 2 types of breech presentation. I get 1 attempt to try and deliver. Buttocks. If the buttocks are presenting, the kid is basically what? Pulled in half. So I'm going to put her on the edge of the bed, set her up a little bit, use gravity. I'm going to have her push, and I'm going to pull straight down and rock that pelvic girdle. I get 1 attempt to try and deliver. If she don't deliver, it ain't the head, put her doggy style, drive fast. If both feet are sticking out, that tells me that the kid's in a straight line. If both feet, I'm going to have her push, gently pull traction, and I'm going to try and pull the kid up. Instead of bending it in half and pulling it down, it would get stuck on its belly and chest. So I'm going to try and, both feet are sticking out, have her push, and I'm going to gently pull up. I get 1 attempt at that. If it doesn't deliver, doggy style, drive fast. If it's an arm by itself or a leg by itself, don't try to deliver that. Okay? Don't try to deliver that.
Just to clarify, technical medical term is Trendelenburg, right?
I
just so
not
I
Trendelin dog.
Trendelin dog.
It's actually called elevated buttocks, knee chest position.
Elevated.
Yeah, Trendelin dog is not
Elevated
Lawyers
dog.
like the fuck.
Yeah.
Yeah.
I want to make sure I get it right.
And if you don't speak very good English, you can get on the jump seat and spank and bark until she flips over. I'm just saying. I couldn't remember how to say dog style in Spanish.
Got it.
Stay a little bit there.
You can ask some of the guys I worked with that were on that call. They're like, it worked though. We got her flipped over. And then we put the blindest guy on our crew to put his hand in there. And I'm calling to see if we can get emergency cesarean to get the kid cut out. And he's now a captain, but we called him Magoo because he wore contacts and birth control goggles. Is how thick his glasses were. And he looks up at me and goes, Dave, I couldn't see what hole was what, so I put fingers in both holes. And I go, you put fingers in both holes. And Dr. Charles Sue, who was the director of Baylor Irving at the time, he goes, you're doing what? Because he got back on the phone, I didn't know it. So, yeah.
I've done that before.
That's the only prolapse cord I've seen in over 20 years.
So,
You too.
Do what?
emergency C-section in the field?
No, we did not do it. I called to see if Baylor Irving could do an emergency cesarean. If they couldn't do it, we were going to Parkland. So we were at Rayo de Sol, which is 2300 block of West Rochelle, just north of 183 of Rochelle and Story. We
get hurt a little bit.
apartments. And we had been to Baylor Irving like 5 or 6 times that day. So I knew Dr. Sue was working, plus I teach all our ACLS at the ER. And so I called him and was like, I need an emergency cesarean now. If you can't do it at Baylor Irving, we're headed to Parkland. So I told Toll, who was our rig at the time, I said, head towards Baylor Irving. If I tell you to go to Parkland, then bypass and we'll go to Parkland. Because I didn't know if Baylor Irving could do a cesarean like that or not, but Parkland can. But I didn't want to drive all the way there in the middle of the afternoon if we could avoid it. So no, we are not doing that in the field. No, we are not. We are not. But
Hey, I was fucking scared for it.
no, but that kind of goes back to making sure we pick the appropriate facility. Middle of the night, Baylor Irving probably wouldn't have had any resources to do an emergency cesarean. It happened to be in the afternoon. They already had a couple scheduled, so they had everybody in the hospital, so they were able to go ahead and do it. But if they wouldn't have been able to, we would have went on to Parkland. If you're one of your close, let's say you're down south and you're not sure if Charlton can do it or not, head up towards Methodist. All right, you're going to have to go to somewhere that can do emergency surgery and do a cesarean. Middle of the night, our smaller hospitals probably can't. Middle of the day, maybe call them and ask them. And that's basically what we were doing. But no, we are not doing that in the field. All right. Meconium is like guacamole. It's a sign of fetal distress. It's in the kid's mouth. Now, you can have meconium staining where the kid was in distress and had a bowel movement during delivery, but not aspiration. Just because it's on the kid's face or in the water doesn't mean the kid aspirated. So if the kid has meconium, which is like thick green or brown guacamole all over its face, but it's pink and actively crying, that kid didn't aspirate it. Now, if the kid is blue, limp, lethargic, and it looks like somebody shoved guacamole in the kid's mouth, that's aspiration. If they've aspirated, we're going to intubate them, and then we're going to suction with the ET tube on the way out to try and get all that meconium out. The reason we're trying to get all that meconium out is because it's thick, they can't exchange oxygen, their immune system's not fully developed, and they can develop bacterial pneumonia the first day of life. When you did adult ventilatory management and deep tracheal suctioning, what were you supposed to do with the French catheter every time you took it out of the ET tube? Clean it in sterile water. For meconium, we're supposed to use a brand new ET tube every time we go back into suction. Or if you don't, which we only carry 2 ET tubes that small, you're going to have to clean it in sterile water before going back in. So it may say you have a kid that's blue and lethargic, you've suctioned, you have a large amount of meconium on your ET tube, no other tubes available, what should you do? Clean it in sterile water. All right, clean it in sterile water before you put it
What
back.
size is that for the newborns?
Probably about 2.5 to 3. Abruptio placenta is abrupt pain with minimal bleeding. What happens is the placenta detaches and tears loose from the uterine wall and it covers the vaginal opening. So a lot of times it's excruciating pain, but they really don't have any bleeding from it. It can be caused from blunt trauma like a car wreck. It can be caused from slamming on the brakes. And if you stop and think about it, if you slam on the brakes, your body's going to go forward till the seatbelt stops it. That fetus is going to go forward until it bounces off the abdominal wall. If it's a significant enough deceleration or they got hit from behind, it can cause that placenta to detach, and they'll have an extreme pain with minimal bleeding after being punched in the stomach, blood trauma. That's a rupture placenta. Best way to keep mom alive or baby alive is keep mom alive. A placenta previa, on the other hand, is a painless bright red bleeding where instead of mom's uterine wall tear, the placenta tears out here way away from the uterine wall. Well, she can't feel the nerve endings of the placenta, so all of a sudden she starts having bright red blood, but it doesn't hurt at all. She's just, all this blood's coming out. The problem with the rupture placenta and placenta previa is mom can go into hemorrhagic shock. Best way to prevent hemorrhagic shock is to keep her alive, take her to the hospital. PID, yes.
So the ripping, tearing, that's uterine rupture?
It's the placenta has ruptured from the uterine wall. That's why it hurts. Versus imagine my placenta is here attached to the uterine wall and it gets cut over here away from the uterine wall. They're not going to feel that cut or that tear.
So uterine rupture and a rupture placenta are 10?
No. A uterine rupture, what happens in a uterine rupture is we deliver the placenta and it never fully detached from the uterine wall. So when the placenta is coming out, it pulls the uterus loose from the body and ruptures it, and it comes out with it. It's also, if it tears, it's a uterine rupture. If it stays intact, it's a uterine inversion. What a uterine inversion will look like plastic saran wrap hanging out of her after she delivers. That's a uterine inversion. So if it looks like all of a sudden saran wrap or contact paper, wax papers hanging out of her, that's a uterine inversion. The uterus is basically collapsed. You get one attempt to fist her and try and put it back in. So you're going to gently take your fist and gently try and push it back in there per textbook. With our transport times, I wouldn't try that. But you get one chance to gently push it back in. You don't want to use your fingers because your fingers will poke through the uterine lining. That's why it says gently use your fist. If it's a uterine rupture, what will happen is she'll deliver the kid, and then when the placenta delivers, it will tear the uterus up inside, and her belly will become rock hard, and she'll have excruciating tearing sensation and a ton of bleeding after delivery. That's a uterine rupture. All right, so a rupture placenta, the placenta tore loose of the uterine versus the uterus tears itself. That's a uterine rupture. And if the uterus falls out, it's inversion.
So
When I did my my clinical
Uh-huh.
for the labor and delivery, we had a female that had the uterine
Inversion?
version. It came out and it looked like those things that they play with, like the string. The
Yeah.
thing.
Yeah.
It came out and it did like that. Like, and then it was bounced. Yeah, it bounced. And
Yeah.
The doctor just placed it back in. Didn't say anything. And I was like, "What the hell was that that just came out?" That's not normal, right? I don't know. It was.
Did they end up taking her to surgery and stapling it back up, or they just go, "Oh, she's young. We'll see if she recovers"?
Well, you say like the kid.
Hang on.
With the uterine inversion, when you put it back in, do you take your hand out?
Yeah.
you got like
It's stuck now.
Yeah. Montez.
You know what? You said the baby has to be like looking healthy, but fuck, the first baby I delivered, that shit, he looked dead as fuck. And I wasn't ready for that shit because it came out.
It takes about a minute for them to pink up and start circulating. They do look pretty limp. And that's why our APGAR waits till the 1 minute mark, and then we check it again at the 5 minute mark.
Okay. So it's 1 in 5?
1 in 5.
So is the uterine rupture not? It's not caused by trauma, but a rupture of placenta can be caused by
Correct.
trauma. Okay.
Correct. Hey, real quick, let's finish this so we can take a break. The PID, the two most common STDs in females are gonorrhea and chlamydia. How they test for it is a G and C test. Don't ask me why that's on the registry, but it is, because they're testing for gonorrhea and chlamydia. All right? It's a GNC test. So if she has fever, foul-smelling discharge, sexually active, that's gonorrhea and chlamydia. It's PID. Because the inflammation of the labia and the minora, they cannot take full steps, so they get the shuffle shade, and they'll do this. PID shuffle. All right, just take full steps, walk away. Remember, if she smells like trout, get out.
What was the test? G and E?
GNC, gonorrhea and chlamydia test. All we can do for it is general supportive care. We have to be aware because of how vascular the female reproductive system is, it can end up turning into sepsis. So we have to be aware that if she keeps that infection too long without treatment, she can end up in sepsis. All right? If it develops sepsis, well, it's a treater for sepsis. But
Painful intercourse too, right?
it can be, yes, because of the inflammation. Ectopic pregnancy. Ectopic pregnancy, any female sexually active, childbearing age, with sharp stabbing onset of pain, we need to consider an ectopic pregnancy. Now, what happens in ectopic pregnancy is usually 6 to 12 weeks after their last period is when it ruptures. So, we have our ovaries, all right? We have our uterus down here, and we have our fallopian tubes that carry the egg from the ovary down into the uterus. For some reason, the egg, she didn't fully ovulate, and a lot of times birth control will cause this, or intrauterine devices. She does not fully ovulate and move the egg into the uterus. The sperm ends up in the fallopian tube, fertilizes the egg. Instead of the egg moving into the uterus, it stays in the fallopian tube, and it attaches to the wall, and it starts to grow. There is some blood supply in the fallopian tube wall to grow this egg for a little while. Eventually, the egg is going to get too big, and it's going to start to pool in that fallopian tube wall. Jogging is the most common exercise that makes it go ahead and rupture. And if you stop and think about it, if you've ever seen like a fruit tree where it gets a bunch of fruit on it, as the fruit gets bigger and bigger, the tree limb starts to bow. And if you shake the tree limb, the weight of the fruit will make it fall off. Well, it becomes so large and so inflamed that when she starts jogging, that up and down bouncing of that embryo will end up tearing that fallopian tube. So she'll end up bleeding internally inside her stomach as a result of an ectopic rupture. So female childbearing age, sexually active, sudden onset, sharp stabbing pain while jogging is almost always the buzzwords they use on the registry. Surgical evaluation, maintain a radial pulse because it's hemorrhagic shock, which is a pressure of approximately 80. Yes?
Can it fall?
It can, but it's still going to be bleeding up inside where the fallopian tube is in her abdominal cavity. She may not necessarily have vaginal bleeding.
That's just pretty serious stuff.
Yeah, I can make her bleed to death and die.
Yeah.
But usually it occurs on girls on birth control or intrauterine devices, and usually in their late teens to early 20s when their cycle's not quite regulated yet. And that's why they don't know for sure if they're pregnant, because their period is extremely irregular. So it's not uncommon for them to skip a month and they're like, well, are you pregnant? I don't know. It's never regular anyways. But usually 6 weeks after their last period is where it grows enough that it can start to rupture. All right, general supportive care, maintain a radial pulse. What size of IV should I use? Anytime you have to give fluid replacement, we want this. Short and fat.
Gotcha.
All right, short and fat. All right, so if it asks you a test question where you're going to have to give volume replacement, and they do this, they go 14 gauge 2-inch, 16 gauge 1.25 inch, 18 gauge 1.25 inch, or 10 gauge in the hand.
That's an asshole move.
Yeah, we're not putting a 10, 12, or 14 in the hand. Really shouldn't put a 16 in the hand. That's kind of unethical. So what's the best combination of short and fat listed?
16.
This is the best combination of short and fat. Think of it like this. What would you rather have connected to your plug? 25 foot of 5-inch or 1,000 foot of 5-inch? The shorter the container or the pipe is, the less friction loss. The problem with the 2-inch 14 gauge is it's going to go through the vessel and it's going to end up having so much turbulence that it's not going to flow as much as that 16. So the best combination of short and fat out of these choices between a 14, 16, 18, and 10 is what? The 16. If I was to make this a 14 gauge 1 1/4" in the AC, now the answer would be, it would be a pipe, but that would be it. So I want to pick the IV that is the most reasonable to put in an AC, diameter-wise and lengthwise. And usually that's going to be a 14 or 16 1 1/4" in the AC.
So, I'm a little confused. You said it was 16, and then you switched to 14 to AC, and then you said that it's the 14.
I changed this from a 2-inch
Oh, okay.
to an 1 1/4".
Okay.
So now they're both they're the same length, but
Wait,
this
you
one's
picked the 14.
this one's fat.
Gotcha. So the 14.2 was just.
It's too long, and it's going to create too much turbulence, and it's too long to do a peripheral IV with. That 14 gauge 2-inch was designed for needle decompression, not for IV.
Are they going to ask a preferable site, like give two
Yes.
of the same needles?
Yes. So what if I did this to you? So let's say I did this. 14 gauge right hand, 18 gauge AC.
What?
18 gauge. You're not gonna put a 14 in the hand.
I got 14 gauge AC, 16 gauge right hand, 18 gauge AC.
18 gauge. I mean 14 gauge.
14 gauge AC. What if I change the 14 gauge to hand?
Nope.
Now what's your best answer?
18 AC.
Yeah.
Juggler.
At 14 and 16 in the hand. So now when I look at size, how close to the heart, that 18 gauge is the best out of those
So you
choices.
just want one closest to the heart.
Closest and biggest to the heart I can get. If I was to make this back to the AC, now it would be the best, closest to the heart, shortest and fattest combination would now be the 16 gauge in the AC. You're going to see one of those on your final. Yeah, that's not cool.
What else we gonna see in that final?
Whatever's in the recording. All right. Come back in at 2:30. And we'll be in the ops packet.